Hello, everyone. Dr. Nikhil Verma here with another edition of Things I Didn't Learn in Med School. Today, I want to talk about something that came across my feed on Facebook. I'm part of a PRP and stem cell community chat on Facebook, and an anonymous member posted that her husband, who had been dealing with knee arthritis for many years now, had stem cells about 5 months ago. And part of the protocol of this practice is to have a repeat injection of PRP several months later. The post went on to go say that despite the stem cells that were done 5 months ago, give or take, the patient's knee actually got worse based off of the X-ray images that were taken. And it brings up a very interesting point. And I think this is a common misconception when we talk about regenerative medicine, and why that's not a term that we'd like to use when we're discussing these with patients. The evidence to show that this actually regenerates a lot of stuff is very, very low right now. What we do know that these treatments, and we'll use a better terminology called orthobiologics, ortho meaning orthopedics and bones and orthopedic structures, and biologics meaning using our cellular biology to help heal. We do see that these treatments, these orthobiologic treatments, help with pain, reduce inflammation, especially the chronic bad inflammation that we might have in the knee or other joints. And also, it can be protective to the chondrocytes. That doesn't necessarily mean it reverses, chondrocytes being the cells on the knees, doesn't necessarily mean it reverses arthritis. It can help slow it down, maybe. I don't want to go and say that outright because it's not the case for everybody. But the idea is that if someone already has knee arthritis, the chances of their knee arthritis getting worse over time is highly likely. We also know, and if you go back to one of my previous videos a couple weeks ago, I talked about how studies are showing even one single injection of steroids is toxic to the cartilage in the knee. And also, we've seen this repeatedly with other joints. That's even just after one. In fact, those patients that had the knee injection were more likely to go on to have knee replacement faster than their controlled counterparts that never had a knee injection despite having the same amount of arthritis in the knee. So it makes a point to think about what happens when patients have repeated knee injections. Does that exponentially or linearly increase your cartilage damage? I don't know. I don't know if the studies are out there, and that's something I'll be paying attention to over the next few months, over the next few years, especially as our practice is going more and more away from steroid injections and more towards orthobiologics. So with that being said, this screen, I want to talk about the Kellgren-Lawrence grading scale for knee arthritis. Now, the most important thing to know about this is that this is a radiographic finding. This has nothing to do with the patient's symptoms. This is strictly for radiologists to give a grading scale on the degree of arthritis in the knee. I know this because I've seen patients with this KL4 severe knee arthritis with very little pain. Maybe there's decrease of range of motion, but very, very little pain. They're still running marathons. They're still able to move around. There is a generalized theory that a KL0 is a healthy knee. KL1 is a doubtful knee osteoarthritis. KL2 is mild, moderate. But again, this is more of a degree of scaling for radiologists, not degree of symptomology of our patients. But let's talk about it. So we see a healthy KL0 with a good joint space in between the knee there, and no osteophytes, no bony overgrowths. In KL1, we have some minimal, if any, joint space narrowing. We might have some osteophyte formations. It looks a little bit irregular. We have definite joint space narrowing in KL2. And then in KL3, there's marked with more osteophytes. And this is when we start getting subchondral sclerosis. That means darkening, or we'll say hyperlucency, of increased whiteness or darkness around the edges of where the knee joint is meeting each other. The top bone of the femur, the bottom bone of the tibia, and we'll see some whitening there called sclerosis. And we might see some increased osteophyte formation. And then KL4 is complete loss of cartilage and bone marrow edema. Now, not quite frequently, bone marrow edema isn't seen great on x-rays, but it can be seen on x-rays. Really, we would need an MRI to look at that. And I have some images of the MRI. Again, this is a frontal view, axial view, and sagittal views of the knee. And we can see this white portion being such that of the knee edema. And moving back to the patient I was discussing, or this post that was on Facebook, again, anonymous member, I have no idea, I have no interaction with this individual, not my patient, but her upset was that the husband was not getting any better. In fact, that there was some potential bone marrow edema that was seen with marked joint space narrowing after the 5 months. At least in our practice, we talk about how the injection itself is not going to heal everything. It's going to make your knee in a healthier environment, or the joint in a healthier environment. It's going to decrease pain and decrease inflammation, as we talked about. It may be protective for the long-term benefits, but the work still results on what the patient can and can't do and their limitations. So this is why I tell all my patients it's a requirement to do a prehab therapy to strengthen the knee, to decrease any inflammatory markers that might be there, to decrease our inflammation, increase our metabolic efficiency. All these things are for the prehab portion. And then after the injection, it's really important to correct any minor differences, any strength differences, any abnormalities to the gait pattern that might be needing addressed. And that's working with a really well-trained physical therapist to address these kind of issues. You can see here that there's 3 anatomical physiological normal variants of how the knee patterns are. There's a normal pattern, we'll say, in the middle. On the screen's left, there is a valgus pattern. You can see where the femurs come in and the tibia and the fibula go out. Again, and then here on the varus pattern on the right side of the screen, where the femur kind of bends out and then the lower leg bends in. So this, and then when this happens, you can see, we'll say on the varus pattern, that when this varus pattern, the bow-legged pattern that we see comes, you see an increase of the lateral part of the knee gapping and the medial part of the knee coming together, likely causing that bone marrow edema if it's going to keep rubbing, especially if there's no cartilage there to protect it. When this happens, that bone marrow edema can come. Now, these quite frequently are genetic variations, or just how we were taught to walk or how we walked over time. And they're very difficult to treat and correct over the years. But there are ways to help correct it. And that works with working with a trained physical therapist that can work on gait analysis. There's also things such as offloader braces that we can put in our knee to help put pressure on the outside of the knee to help take that load off the inner part of the knee. There's also foot wedges you can put into the foot, into the shoes, to help offload that inner part of the knee. And it'd be the vice versa for the valgus knee deformity that we see here. I believe that's one of the reasons why the individual's knee got worse, was because that grinding on the medial part of the knee causing bone marrow edema. And they just did the injection expecting it to fix everything without taking the necessary steps to work on the gait analysis, knee braces, foot wedges, et cetera, et cetera. There might be some muscle imbalances there that can quite happen when we have pain disinhibition of the muscles. They don't fire appropriately, they don't fire correctly when we do have pain, and that changed our gait pattern too. Now, one interesting thing is when we do stem cells and PRP into the knee joint itself, it doesn't always treat the bone marrow edema. So, what do we do? Our field is going more towards a concept called intraosseous stem cell injections. And again, when I say stem cells, I'm talking about mesenchymal stem cells, either coming from your bone marrow or fat, not off-the-shelf products, not umbilical cords, not embryonic tissue, not exosomes. That's a whole other reason for that I'm not going to talk about today. But so in these settings, it's a little bit more of a surgical procedure than just a procedure done in the basic outpatient setting, though these are frequently done in an outpatient setting, is you'll take a small needle and actually drill into the cortex of the bone and fill up some of that area with stem cells. Now, the potentiation of this is great because that area that has the edema and swelling does not have a great blood flow. So it needs to have an increased factor of getting to that site to help heal. Studies are really preliminary on this right now, but from what I hear from my colleagues, not something I've done yet myself, that the outcomes are fantastic. And they are actually seeing changes on the MRI. Now, again, very preliminary. I do not want to say this outright yet because I don't know if it's true for everybody, but the preliminary studies that my colleagues are showing me that has been presented to me and that I'm hoping to learn more in the Orthobiologics Institute conference / IOF Max conference that I'm going to this June in 2026. I'll learn more about this and see what the newer studies are showing. To summarize everything about what we're talking about today is PRP, stem cells, these procedures, they don't necessarily slow down the arthritis to a stop. They can slow it down, hopefully to a snail's crawl, but not everyone gets that benefit. Our major goal is to decrease pain, decrease inflammation, increase functional status. Whatever the x-rays and MRI shows, they show. And that's my opinion, and that's how I feel like I'm treating my patients. And that's what I need to explain to patients, is if we can get your pain reduced, inflammation reduced, your function increased, you can enjoy life again. You can start doing those things that you're struggling to do in the past. That is probably what's most important to me, and that's why I present it to my patients the way I do. And this isn't just a one-time injection. It takes work from the patient before the procedure, time of the procedure, and after the procedure. And sometimes it takes some maintenance of more procedures, more injections, PRP, down the road. 6 months, 12 months, 2 years. Everyone's a little bit different. But knock on wood, we've been seeing some really, really good results with our patients, even with severe arthritic changes that were ready for surgery. I hope you guys found this useful. If you do have any questions, feel free to drop them below. Feel free to message me directly on any of the social media platforms, DRNV Sports Spine or DRNV Sports and Spine. And don't forget to like, subscribe, and share. We'll talk to you soon. Bye.